Ministry of Health that we should resume services. Some areas I know services have been continuing. There are hospitals which never closed down. They still continued offering their usual services to their patients. But in some facilities, from the last discussion we had, some of them had totally closed down. So we're very excited today. We have Dr. Pacifica Onyancha from the Ministry of Health, who will be taking us through this particular topic. And we also have Dr. Walter Odhiambo, representing the dental and maxillofacial, our dental and maxillofacial colleagues. He was also here in another forum a few months ago, and he did a fantastic job. So now we want to hear from him as we resume our dental services, what they'd love to see or what they'd encourage their his fellow colleagues to do. We also have Dr. Morino Witi from Kenyatta National Hospital. She's an obstetrician gynecologist. And we will be talking about resumption of antenatal clinics, postnatal. We may not be able to talk about immunization services because not unless Dr. Morino would love to into that. We are waiting for Dr. Kimani to join us and brief us about resumption of elective surgeries. We hope to get him on board. He's currently caught up in theater, but we hope to get him on board. But if there's a surgeon in the panel, kindly alert us and we'd love to hear from you. And Dr. Andrew Owor, who will tell us about resumption of medical outpatient clinics, if they ever stopped. And now that we are resuming, what are we advising the patients? I'd really love to hear from the participants, wherever you are, at the county level, at the national level. How would you like this to be done? How are you proposing, whether in private sector or public sector, how are you proposing that we bring back our clients? We know bed capacity went down, our inpatient numbers went down, and this cut across all boards, private, public sector, clinic attendance went reduced. So we would be very excited to hear from you in the Q&A section. How would you like this to be done? How can we inform our patients that we are back and we're offering these services and they should come for their routine services? So I'd like to get the panelists to greet us, and then Dr. Onyancha can start the presentation. So we can start with Dr. Morino Witi.
Dr. Kalondu.
Thank you very much, Dr. Kalondu.
Yes, Dr. Kennedy.
I think you have to hold on a bit.
Okay.
Dr. Pacifica Onyancha is just joining in right now.
All right. Okay,
yes,
let's give her 5 minutes.
1 or 2 minutes. Yes.
All right.
1 or 2 minutes.
Okay.
Yes.
Okay. Thank you.
I don't mind saying hi to all the participants, and I'd like to say thank you to the organizers for inviting me to be one of the panelists. I'm very honored and humbled to be considered for this presentation. I'd also just like to inform Dr. Kalondu that obstetrician gynecologists are also surgeons. So in case Dr. Kimani doesn't come on, I can hold brief for him. Thank you very much.
Thank you. Thank you, Dr. Witi. Thank you for that. Thank you. All right, Dr. Walter Odhiambo. Dr. Odhiambo, please unmute yourself. We can see you talking, but we can't hear you.
Okay.
Yes.
Thank you very much. And good afternoon, dear colleagues.
Good afternoon to you.
I also wish to express my gratitude to the organizers of this webinars for inviting me once again to share some thoughts on this critical moment that we are going to discuss about the pros and cons of getting back to work and how well we can keep safe ourselves and our patients too. So I look forward to a good discussion. Thank you.
Thank you. Thank you so much. As we wait for Dr. Onyancha, Pacifica Onyancha, to join us and share with us the guidelines that they've developed, I'll just answer a question that somebody is asking. Somebody is asking, why are pharmacists not employed? Unfortunately, I am not in a position to answer that. So that you don't feel like I've dismissed your concern. Unfortunately, I am not in a position to answer that particular question. So kindly let us know in the Q&A section what you'd like to see as a healthcare worker, wherever you're working. I know there've been quite a lot of concern about pharmacists at the chemist level, the ones who are dispensing drugs. Yesterday, there was a concern about how are you taking care of us who are distributing drugs at the estate level. So let us know what you'd like to see and how you propose, the measures you propose about your own safety. How do we take care of our own well-being as we resume services? It would also be good to hear from our anesthesia colleagues. I don't know if there's any in this forum, but it would be very good to hear from them, the proposals that they make, because most of the activities are also generating procedures. So we'd really love to hear from them, what measures we need to put in place before we start resuming our elective theater cases. So,
Dr. Kalondu,
yes.
Prof. Ndwati is also on.
Oh, fantastic. Okay. Hello, Professor Ndwati. I guess I can see we have Professor Ndwati and we also have Dr. Maritim.
Hi, I'm here. Thank you.
Yeah. Yes, thank you for joining us. And we'd love to hear your sentiments once Dr. Onyancha presents on how we can open up and resume our normal medical services. I know they've still been going on in some areas and the areas which have really suffered. So we'd really love to hear how best we can protect and still continue giving our immunizations, still having our NC clinics, well baby clinics. That's the topic for today.
Okay. All right.
Okay. Give me a second as I look for Dr. Onyancha.
I'm in. I'm sorry. I was not able to unmute myself. I'm in. Dr.
All right.
Onyancha.
Karibu, Dr. Onyancha. Welcome to today's forum, and we are excited to have you. My name is Dr. Rhoda Kalondu from KNH. My co-host is Dr. Rosa Chemwei, and we also have Dr. Kinuthia, who is planned this program. Part of our panel team, we have Dr. Maureen Owiti. She's an obstetrician gynecologist. She's representing the reproductive health department or the reproductive health colleagues and also the surgical colleagues. We have Professor Ruth Ndwati representing pediatrics and also maybe the university level, because that's also a conversation that needs to happen at a different forum or maybe this forum. We have Dr. Walter Odhiambo representing our dentist and maxillofacial surgeon colleagues. And we are hoping to get a physician as we continue. One of them is supposed to log in and join the team. So karibu sana, Dr. Onyancha.
Thank you so much.
If you're ready, you can start. Mr. Mwenda will be sharing your slides, will be rolling out your slides for you.
Okay, I just want to request for your indulgence that I've just finished another meeting on stigma, which is really part of what has caused even the utilization of services to really go down. So I'll just request that I reach the house. I'm just here opening the gate so that I can plug my phone, or I go to the computer because my battery is quite low. But I will be with you. Just give me 2 minutes.
All right, we'll give you 2 minutes. It's okay. Just let us know when you're ready. Okay, I would like to thank you for your concerns in the Q&A section. There are those ones who asked about jobs. Unfortunately, I am not in a position to answer about biomedical laboratory science degree and employment questions. So kindly let's limit our questions to the topic of the day, where we're talking about maintenance of essential health services. Let's limit our questions to that. Leban Mayo, kindly write us an email and we'll be able to respond to your question about CPD points. So Faith Kilonza is saying, I am in private practice. We are sending bulk SMSs to our patients to find out how they are doing and informing them that we are here to serve them. We are also reassuring them that we've taken measures to ensure their safety through the use of PPEs. That's a good initiative, Faith. And it's true, this is the time to change the way we've been doing things and to invite our patients back. Okay, yes, Dr. Wambani, you can make a comment as we wait. Let me just look for you and unmute you. Let me see where you are. Hello, Dr. Jessica Wambani.
Hello, good afternoon.
Good afternoon to you.
Yeah, these sessions are very educative and I'm very impressed by the way you have organized them. I would like to make a comment after listening to this morning session. Yeah. I think health has been under-financed and we've never met the 15% Abuja declaration for health budgets in our country. The most we've gone has been 7%. So during this COVID, I think we need to preserve our health workers. We shouldn't get any health worker infected. So the mechanisms that many counties have put in place to protect health workers, families, and themselves, I think we should just embrace them. And then we will assess how much budget we have used during this endemic, whether it has gone beyond the health budget, then we can say that we don't have funds, but it can also be used for future planning of the health budget. Thank you very much. That was my comment.
Thank you. So I hear you talking about resource allocation and more specifically budgetary allocation.
Yes, to the health.
To the health sector.
Yes,
Thank
the
you.
most we've had has been 7%.
Yes.
If I'm wrong, I'm not wrong, because
yes.
I've been following up the budget and looking at the research that needs to be done in terms of health. Yes. And what is limiting is usually the finances for research.
That's true.
Thank you.
That's true. Thank you very much. And you've actually given us a suggestion for a topic, financing for healthcare. We will see whether we'll be able to have such a session. It may not be COVID related, but it would be good for us to understand how this financing for healthcare works. So thank you for that, Dr. Ambani. Timothy Mushiri is saying the government has spread more fear than caution, leading to decrease in the number of patients attending clinics. The worrying trend is self-medication has been on the increase. Thank you, Timothy, for that input. Dr. Rukia is saying we will have at least basic standard PPE. Oh, she's asking, will we have at least basic standard PPE, especially surgical masks given daily to healthcare workers, considering the flow of patients will increase? Because currently we are being given one surgical mask to use for more than 3 days. It is very stressing. Dr. Rukia, please confirm, are you being given one N95 to use for more than 3 days or one surgical mask? Kindly confirm and let us know which county.
I'm in now. Thank you for being patient.
Thank you, Dr. Nyancha. You can proceed.
Okay, thank you so much for giving me this opportunity to be able to present some of what we are doing in the ministry. And just to start is to thank the organizers for seeing it necessary that we be able to be together and be able to address this very important issue, the issue of healthcare services in the face of COVID. And even though my slides or my title is maintenance of essential health services, I think what will be more appropriate is that even starting, because we really want to go back, because there's some services which were put on hold. The reason why we thought we could have this conversation is that as a committee, you can see it's a committee which has been set up for maintenance of essential healthcare services. We realize that the problem is not just maintaining, but we may want to reverse or to halt, or rather reverse, because a lot is not happening. So my slides will basically be showing you what we have discovered as a committee, that we are not just going to maintain, but we have to look at mitigating factors to be able to bring back the services as they were before we can even maintain. So I'm just going to give you just an introductory, the objective of this committee, and maybe just rush to the point, the slides which will be showing us analysis of what is happening as far as service delivery is concerned. And this is really from the DHIS, because figures don't lie, so that we can be able to start the conversation there, that we really want it to continue like this, the effects that it has had in the healthcare service delivery, or we really want to reverse the trend and be able to see whether we can reach a point where now we can maintain the delivery of essential healthcare services. So whoever is doing the slide, we'll go very fast. I don't want to bore you with a lot of it. So can we go to the next slide, please? So this is really a presentation which I did to the National Task Force on COVID. But then why I just want to pick a few slides which will be relevant at this moment, so that I can be able to allow you to allow ourselves to be able to contribute the way forward in terms of really addressing issues of healthcare service delivery in the face of COVID. Next. So I don't want to go details, please continue. This one is just telling you this committee was established so that it can support the MOH to actually see to wish that the increased indirect mobility and mortality due to the COVID may not really take place, and therefore it is like a custodian to make sure that services go on even as the other people are responding to the pandemic. Next, so our main objective, which I want us to move very fast, the first one is to support the development of guidelines and support and advice on the coordination of the functions between the national government, the national task force, other stakeholders like the counties and the private sector and all that. And also to provide technical direction on the maintaining of essential healthcare services. And as I've already said, that we discovered as when we were doing the analysis that really it's not just about maintaining, but we may want to go back and be able to see how do we revive some of the services which are not taking place. Next, please. I just want us to move very fast, forget about the objectives and move to the structure. Is not important because it's just to showing that we have got 5 subcommittees which are looking specifically to the guidelines, because as just before that, just go back. We realized that as we were going on with the fight against COVID, we realized that the various departments, thematic areas actually developed the guidelines which were discrete, and they were sent to the service delivery areas to be able to guide in the essential services even as we were fighting COVID. So the guidelines, the first working group is actually looking at the various guidelines, putting them together, have one guideline so that it is user-friendly to be able to support in the continuity of essential services. The second group is actually looking at prioritization of the essential health services. Which are these essential services that really must continue? We can actually make sure if they have declined that we bring them back to where they were and continue like that. And another group is one of the groups that is looking at the data that is informing us how we are doing going forward, and actually also the monitoring and evaluation on what is happening on the ground. The next group is really the one of risk communication. Once we have found what is happening, how do we package how do we engage with the stakeholders? How do we engage with the healthcare deliveries? How do we engage with the communities, the people who are unwell, who are not seeking services? How do we make them to come back and be able? So those are the ones who will be fed from the other communities to be able to know what are they communicating. And the last one is really to look at transition into early recovery and links to the UHC to make sure that we are able to recover the effects of COVID and be able to continue in rolling out our UHC, and of course making sure that the people don't suffer unnecessarily because of failure of service delivery. Next. Please skip that next one, what we have accomplished, and go to the data, so that, because I want to be very brief so that we can proceed to very valuable input. So from what the analysis that has happened, evidence has indicated that there has been a significant drop in the essential health services utilization during the COVID-19 outbreak as compared to the pre-COVID-19 situation. And what this group has done is to compare the same period last year and this year, and this is what is coming out, that this decline is particularly pronounced in following health services. We have seen a significant decline in the OPD attendance by general population. There is OPD attendance decline by children under 5 years of age. There is a significant decline in antenatal care and by pregnant women. Routine vaccination of children has declined. Vitamin A supplementation has also declined. And identification and treatment of communicable diseases, particularly malaria and TB, and then enrollment of new HIV patients for ART treatment has also significantly declined. And also identification and treatment of non-communicable diseases like hypertension and diabetes, screening for cervical cancer, all these have really declined. And therefore, there are also concerns regarding the availability of essential medicines, because as part of the analysis, they have really looked at the tracer drugs and the availability of these commodities, and we are seeing that they also are affected in terms of availabilities. Some health services are found to be more resilient and remain less affected, but in generally, the majority of the health services are the ones who have been affected. Next. That is a graph presentation of what actually we have just put in that picture, in that slide. For example, the percentage of change in OPD visits by county, this has gone down to see how actually most of the counties have the service delivered in various counties, except for Kakamega County, which you see, and I would really want to know, because these are lessons learned. I don't know what they did right, because for them, it seems that they have really not been affected so much. But when you compare with last year, attendance, there's still a significant drop, even where we are seeing positive on the graph. So you can see majority, the effect is very different in different counties. And you can see the worst hit in this particular indicator is the Meru County. Next. I think same, showing the visits by children under 5. And I think of importance, I want us to note is that the blue one is the 2018, the red one is 2019, and the green one is 2020. And we can see how we have actually dropped between the month of March and April. There's that significant drop in terms of visits, outpatient visits by children under 5. And then one is left to wonder, is it that the other diseases feared COVID and therefore people are not getting sick? Or is it that people are so scared of even bringing children to the facilities in fear of contracting COVID, in fear of, I mean, there are so many, and I think that is one of the things that we'll be discussing. And then how do we mitigate a need towards the, to make sure that really we are able to reverse this. Next slide. So I think they're still the same. This is the percentage in under 5 OPD attendance. I think we are talking about the same effect. Can we move to the next slide? And I want almost to stop there. So the difference between in bed occupancy rate by county, still you're seeing even the inpatients is affected almost equally. And therefore, it means that actually services have been negatively affected by the COVID. Maybe most of us were taken to COVID to respond to COVID. Maybe the healthcare workers are not in the facilities, or even those who are there, maybe they are concentrating on COVID. I think we want to hear from people why probably this kind of picture that we are seeing. Next. Can we move faster from the knee, because it's actually the same being shown in pictorially. Can we move to the last slide and see what is it that we are looking at now? Acute issues for COVID-19 that we were discussing with the National Task Force is that the evidence shows that there has been a significant drop in essential health services utilization, as we have already seen. And therefore, the needful action which guidance is that what is it that we want to do? We concern regarding availability. The concerns again from what we have heard is that some of these services have been affected because there are no PPEs for healthcare workers, and of course, where nobody really wants to risk their lives, even though they are going to save lives. So we really wanted to understand from the National Task Force what is it that we are doing in terms of providing PPEs in these facilities to be able to encourage, because PPEs is not just for the healthcare worker, because it's also going to protect whoever is seeking for service in these facilities. So we have recommended that we establish an appropriate PPEs that we make they ensure that there are PPEs in the health facilities, so that they are able to offer services, and also even at the level of community health volunteers. Also, in terms of these PPEs, which ones should be given? I was listening, and I think it's one of the things that I'm hearing, that maybe a healthcare worker is given one PPE to use for 3 days, and I think we want to discuss this. How has that one impacted on service delivery, and what can be done? So I think basically these slides were, this presentation was just to provoke you so that you can be able to come with ideas, to be able to say, how do we go back to the normality without necessarily exposing the healthcare workers? And also, how do we make sure that we are not going to just take a roof and then leave the healthcare services affected by the COVID response? I think my last comment will be that from WHO, we've been told that COVID is here to stay. And therefore, other than just maintaining, I think we will also be able to find a way of coexisting, such that the strategies will be addressing integration within our healthcare systems with the management of COVID, not the way we are actually handling it now. I think I want to stop there and be able to now have an interactive session, get inputs to how we want to go back to normalcy without necessarily risking the healthcare workers, risking anybody who is coming who doesn't have this disease. He should not be able to get it in our facility. Over to you, Dr. Thanks.
Thank you so much, Dr. Nyancha, for that presentation. We are excited to see the diagrams and the figures. It's a very easy way of presenting the data. And I'd like to start with Dr. Walter Odhiambo. Hello, Dr. Walter.
Hello.
Yes. Now, yes. From the figures that we've seen, I'm not seeing anything on dental. Are you in a position to just give us an overall picture on whether there are any services that have been offered, whether there are any that have been offered in the last 3 months, in the public sector? Because I believe these figures are for the public health sector. And how do we go back? How do we resume?
Sorry. I think a point of correction, Daktari. Sorry.
Yes.
These are figures from DHIS, which addresses across board the private, the FBOs, and the because everybody, unless they don't report. So everybody reports on this platform, and therefore this is really across the country. And again, another thing I just want to comment is that we are looking at attendance regardless of what the person is coming to seek for. And we're actually looking at children and adults, and maybe more specific, for example, in antenatal. But otherwise, this is generally outpatient attendance and admission, regardless of the SAT. So there's no segregation. The data is not segregated. Thank you.
Okay, thank you so much, Dr. Onyancha, for that clarification. So, so now my question now goes back to Dr. Odhiambo. Dr. Odhiambo, how do we
Thank you. I want
resume our services? Yes.
I want to thank Dr. Pacifica for sharing with us the data from the National Task Force. And my comments, let me just first make some general comment, and then maybe I can be specific. If we look at the COVID response in Kenya, the initial stage was that of panic, which I think was general for everybody. And in panic, everybody retreated and looked at where the enemy was and maybe to know how to confront the enemy. This was followed by fear. We are in a state of panic, and then there was fear. And a lot of issues, questions raised by Dr. Onyancha really have their answers in that two stage, one of the panic and fear. And the information that came from the ministry to all of us was that suspend all the non-essential health services. And even those who are sick, the information was that keep out of the public, do not use public transport to get to the health facility, and try as much as possible, if you are sick, to stay at home. So a lot of this information, I think it is now that knowledge is coming in. And I think what we have to do is that with this new knowledge, now our response has to be redefined. But there are a lot of things that are not straightforward, because even as we now ease and try to reopen, we know that there are certain conditions and terms that must still be met. So for example, now when I go to dentistry and even practicing of maxillofacial surgery, when I presented here initially, the real concern was that these professionals are highly aerosol generating. And in a situation where now we are assuming that the disease has spread into the community, then we have to reconsider the levels of personal protective wear that we use. There may be areas where we can simply use masks and gloves, and there are areas where you need disposable gowns, and then there are areas where we will need a full protection. But we all know now that the disease is in the community, and we are not sure who is infected and who is not infected. So the cost of care is going to be very high. The dental school, for example, University of Nairobi, we are thinking of recalling our students, but we are already wondering who is going to meet the cost of the personal protective wear. Some of them quite expensive. And if we are going to dispose them after single use, and yet most of our patients, we know their socioeconomic status is very, very low. So this is a discussion that I think we should have very frankly with the ministry. And ideally, what we have to agree on is that some cautionary levels have to be revised. And the main revision that can be done will be by training the frontline healthcare professionals, those who are going to be treating these patients. If immediately we start treating the patients, we will need probably that those being treated be tested, and those treating them be tested, and how frequent should this test be conducted? So a lot of things for us to address before we can have the courage to move to the next level.
Thank you so much, Dr. Biambo, for that. And thank you for bringing the issue of the cost of care and who bears the cost. I don't know if you have anyone from insurance sector or from NHIF in the panel who can be able to, or in the participant section, who can be able to give an input on that. I'd like to go to Dr. Maureen Owiti. Hello, Dr. Owiti.
Hello, Dr. Kalondo.
Yes, now you've seen the antenatal care attendance reduced by a significant level, screening for cervical cancer, also enrollment of new HIV patients. So going forward, and so that we also offer comprehensive care to our patients, how do we resume these services? How do we recall back our patients? What measures are you proposing that we put in place for the staff who will be working in those areas and also for the patients?
Thank you very much, Dr. As you know, since COVID started, there have been a lot of activities that have been going on. I've been very fortunate to be part of the task force for Kenyatta Hospital in terms of preparing SOPs for our department on how we're going to resume services. As you all know, fortunately for obstetrics in terms of delivery and all of that, those are essential services that have been continuing, and we noticed a massive drop in terms of the attendance has been demonstrated by the slides by Dr. Onyancha. So we developed a guideline, and the issue has been you have to resume these services, bearing in mind not just the PPEs, but also the issue of social distancing. So you find that the numbers you're able to see will not necessarily be the same numbers we're seeing previously, or you'd have to have a robust way of increasing the space to enable the social distancing issues. I feel, as Dr. Pacifica has pointed out, the WHO has said COVID is here with us to stay, and going back to normal, my take would not be going back to normal. Then we're going to have what is going to be a new normal. A new normal currently is when you go outside, you're wearing a mask. In fact, if you see somebody not in a mask, you start wondering what's wrong with this person. And then you'll be like, they're not wearing a mask. Whereas previously, that was practically unheard of. You only ever used to see Chinese wearing masks and used to wonder what's wrong with these people. I'm hoping, in as much as it's here for a long time, that we will get gains. But back to your question, I had a fantastic team, and I really like to commend both my team at Kenyatta National Hospital and the university, and very much our students. They had fantastic ideas on how we're going to. We also borrowed a lot. Ministry actually has guidelines on how to manage antenatal patients. So what, for me, is what is going to be the new normal. The new normal will be, we have to invest a lot on areas of telemedicine. So as one of our colleagues has pointed out, the issue of SMS, you really have to screen and triage the people who are coming into the clinics so that you're really seeing those people who need to be seen. So through SMS, phone calls, or even other forms of telemedicine, you're able to screen and say, okay, can you even have the visit via telemedicine? The issue would be, is the infrastructure there to be able to handle such telemedicine, especially in the public hospitals. Aga Khan, I believe, have already started, and a lot of the private hospitals already have a platform where patients can actually be seen on an outpatient basis via telemedicine, and they're able to receive care in that manner. Other issues are, you'll identify this patient who now needs to come. You have to give them instructions on how they are coming. If at all they need somebody extra caregivers, how many caregivers they can come with, because you still have to maintain social distancing. I was very happy, one of our students proposed that we zone the antenatal care. We have already zoned our clinic so that you have areas which are green areas. So a green area is a relatively safe area. So when a patient comes in, they're going to have a triage. The triage is already done through telemedicine, hopefully. At present, we do not have that. So our patients are still coming, and we have our nurses who are triaging patients outside the clinic or at the entrance of the clinic. And the triage is in 2 phases. whereby we're triaging for COVID, and then you're triaging again for the clinical reason why they're here in the clinic. Once the patient meets the criteria to be seen in the clinic, they're given a clinic, their files are retrieved or opened, and they're able to be seen. We had issues of not even just the PPEs, because the assumption, let us for this case that assume that the staff are wearing adequate PPEs, it cannot be a full hazmat for everybody. So because we are hoping that the triage would have picked up symptomatic, WHO is trying to tell us that it's only the symptomatic people who are shedding the virus and are infectious. I don't know how true that is. The debate has been on whether they are symptomatic or pre-symptomatic, but that's a debate for another day. Back to the question that you've asked me. So you've screened, she's asymptomatic for COVID and has an issue that needs to be attended in the clinic. The staff are obviously going to be having the surgical masks. The patient goes into the consultation room, is seen, and you find that once a patient has already been seen, the whole room either has to be cleaned with chlorine, so you have to get in support staff to come and clean the room. The nurses have been very helpful in this. They've been providing fresh sheets for the patient, if you examine the patient, and these are removed and put in a chlorine solution following that. The doors, there was a recommendation that even the doors, handles, and everybody always do the hand washing. Hand washing is before you see the patient, after you see the patient. And we all are advising that the healthcare worker also wears gloves if they need to touch the patient. And with that, that's for us, we are not having the numbers that we're seeing, but the truth of the matter is, until this COVID is neutralized, we will not go back to normal. So I'd like to end with that. I just wanted to comment a little bit on surgery, because that is something that we are doing. I'm very proud to know that we've done, last week we've been having elective oncology surgery. As a department, we looked at it that the oncology patients cannot wait for COVID to end. So in as much as they're telling us to resume, we did not stop. We cannot continue at the capacity that was there because of all those considerations, but we have been doing something on elective. And in as much as there was a directive to resume elective surgery, the issue, and I really loved the wording, was judicious. So it was, everybody was determined what is judicious to do, that you feel that if this person does not benefit from surgery or other services, you see how you can support them. We're also very proud from my department. We have one of our staff who has gotten a commendation for doing a cesarean section on a COVID positive patient. I can even report, as of yesterday, we had another emergency cesarean section done on a COVID positive patient. So services have been continuing. We will continue, and even for the elective surgery. However, the word we have to use is the new normal. It cannot go back to what it was pre-COVID. Thank you very much.
Thank you so much, Dr. Owiti. It's true, this is the new normal. We cannot go back to the way we were pre-COVID. There are two questions I'd like to, one I will ask to Dr. Maritim, the other one I'll ask to Professor Nduati. And let me start with Professor Nduati. Now, Professor Nduati, hello. Hello, Professor Nduati.
Hi, I'm still here. Yeah.
Yes. Now, we've seen there's a significant reduction in the OPD attendance by children under 5. We've seen there's a reduction in routine vaccination. We've seen there's a reduction in vitamin A supplementation, and also enrollment of new HIV patients. I'm assuming also the pediatric age group is factored in this. And there's a very interesting comment from one of the participants, and they're saying socioeconomic parameters have a great role to play in the drop in terms of health-seeking behavior in the era of COVID. Now, we all know economic stability has been an issue for a big percent of our population, a big percent of the Kenyans. People lost their jobs, others have not been able to recover from that yet. And also the access to care has also been a challenge. It has not been very easy to go to the facility, either due to the fear or the stigma. So my question to you, Professor Nduati, is how do we bring back our babies, OPD attendance? Where are these children going? I know you might not have the answer to that, where the babies are going, but how do we make sure the mothers are seeking care without fearing? How do we make sure that babies are getting their routine vaccinations in all the counties, at all the county level, and also the vitamin A supplementation, which we know is very important? How do we bring them back? That's my question to you.
Thank you. Thank you very much, Dr. Kalondu. I think that is a really important question and a big challenge to us as the healthcare system. My reflection on this is that when COVID came, we focused on COVID and focused on delivering safe health worker protection within the areas where we are seeing potentially seeing COVID patients. And we have not given the same level of investment in the other areas like MCH, where it's perceived as a low risk for infection with COVID. Unfortunately, I think the public are worried. And when you're worried, the first people you keep away are your children. We closed school. So if it was not safe for the big kids to be out there, then parents will actually see that it's even more unsafe for the little ones. And so really we'll just come to a facility minimally. Now, having said that, I think we have to be in a new normal. I like what Dr. Maureen has just said. The MCH typically is a busy place. At the hours, usually in the morning, it's bustling with activity. There are mothers with babies, there are the antenatal moms, and there's lots going on because we normally give an integrated service. So even family planning is in the same space. We have to be deliberate in helping the counties and the county teams to plan how they can achieve social distancing in that space. We have to plan for PPEs for the staff in that space. We also have to plan that the public also is using some level of PPE, so at least they are masking as they come into the facility. We also need to think through carefully of some of the services we provide. We provide immunization, but we also do growth monitoring. The typical story of growth monitoring is one weighing scale, which is shared by all the babies. There's usually an effort to manage hygiene by having a mother use her own baby wrapper on the weighing scale, so that you're not, sort of mixing babies one after the other. But now with the new normal, this level of hygiene needs to be upgraded. And I don't think we have done that. I don't think, my impression is that we have not done enough in helping health workers at the level of the health center and dispensary, where a lot of this MCH stuff is done, to know how to function safely and to reassure their patients that the services are safe. As we are discussing now, I understand we have a second health facility in the city of Nairobi that was closed down because I believe all the health workers were COVID positive. Now that happens because there was no appropriate personal PPEs being used by the staff. There's a lack of knowledge of how to do it. So I think for us to achieve a new normal where patients come back for the immunization, we need to make our spaces safe. So safety is not just in the where we are triaging patient coming in who is sick and who is ending up in a COVID isolation unit. It needs to be everywhere else. We now understand that about 88%, the current data, 88% of people who have corona infection are asymptomatic. So they are in the spaces where we are. The public hear this information. So there is concern, and so we need to do that. Now, having said that, immunization is very important, and it actually prevents horrible diseases. Some of them, I think, way worse than this corona infection. So we do need to go out there with clear public health messages that babies need to be protected. We don't want to go back to stories of, rotavirus diarrhea, Haemophilus influenza, meningitis, whooping cough, all those things that you learn about which we don't see. So there has to be a concerted effort to do that. I think the third thing is that we also need to think of our workforce. Generally speaking, the MCH is usually run by nurses who are the more mature nurses, the slightly older. We need to think about their safety as well. And I believe if we have clear messaging out there, we should be able to reverse that particular trend. But we do need to have some discussion of what is essential. I think the immunization is essential. I'm not so sure weighing the babies is as essential given the circumstances that we have now. Thank you.
Thank you so much, Professor Ndwati, and I agree with you. Let's not undo the gains we've made. We've made so much gains, especially in our indicators. So let's not undo the good that we've done over the years. My next question goes to Dr. Maritim. Hello, Dr. Maritim.
Hello, Dr. Kalonde, I'm listening.
Yes, now there's a very interesting comment from a participant, and he's quoting the Cabinet Secretary of Health. And
yes.
The quote is put is, if you behave normally, this disease will treat you abnormally. So that is the messaging that we put out there, and the public has probably taken that message, and that's why we're seeing the statistics that we're seeing at the moment. Mm-hmm. How would you propose that we change the messaging that we put out there? How do we advise the healthcare worker to remove this fear? Because I'm seeing a lot of people are saying there's stigma, there's fear, the patients are fearing to come back, but services will come back slowly. So how do we undo the damage, the silent damage that has been done by some of the statements that have been carried out in the press conferences?
You've given me a very difficult question. So when you look at the messaging, we sort of have contributed even to the decline in the patients, because when COVID came, we told patients keep away because you're likely to get COVID, stay away, non-essential services. So the challenge with that is that the difficulty is that we have sent the message that our hospitals are not safe, and then the numbers have gone up. So when the numbers are going up, we are telling the patients now come back. So you see, that one is a bit contradictory, because the patients now are wondering, like, the numbers were low, you kept us away. Now the numbers are high. How are you now telling us to come back? So I think for us, we need to relook at what exactly do we need to put in place to ensure the safety of patients, that balance between the safety of patients even as they come back to facilities, and even the safety of the healthcare workers. And as we know, the more you have community transmission, we currently know from our statistics, a large proportion of our patients are asymptomatic and mildly symptomatic, and therefore they will be coming for their other routine clinics, but may be positive for COVID and they may not even know. So this puts healthcare workers at risk, even puts the other patients really at risk. So we really have to balance, and those practices of making sure that all the patients, we already had a session on traffic care bundling to make sure that even within our hospitals, we are having a very proper triage system where we are able to identify and consider like any patient is high risk. And therefore we socially distance them even as they wait in the waiting bay. As Dr. Maureen clearly said, we make sure that they all wear masks, they all do hand hygiene as they're coming into, a supervised hand hygiene as they're coming into the hospitals. For patients who will have symptoms, we need to find out a way of putting them in a different waiting area so that you don't have a persistently coughing patient in the ANC clinic sitting alongside other patients, because even the other patient would be fearful of that. So I think even for the messaging for the CS, it's really up to us. And that's why I think the importance of this today's session, that we put our heads together to see, even as we message to the patients, are we even confident that our waiting bays are fairly safe enough for our patients? What can we do in terms of engineering controls? What can we do in terms of administrative controls? And Dr. Maureen mentioned the SOPs that have already been developed. Have we even piloted them this week to see whether they serve the purpose that they intended to? Because you can write something in paper, But when you start implementing them, then you find it's difficult to implement. Maybe you wanted a few patients to be seated together. Can we even have waiting areas that are outside in the sun where people can wait instead of waiting in clinic 16 or clinic 17 to have a proper area? And then even for patients, how do we reduce even the relatives who accompany patients to clinic? Can they have another place where they can sit so that they don't have to crowd the clinical area? So we still have a lot of things to put in place. And I think this is the right moment because the patients are starting to trickle in. How can we refine our protocols in this time when the patients are fewer? For the areas where the clinicians sit to review patients, can we put a clear glass that separates the clinician from the patient? And maybe, I don't know what you can do in the exam rooms. There may not be so much to do, but we limit and we make sure maybe there's a lot of ventilation in the examination where the couches are placed so that even the patient and the contact, like the contact between the patient and the healthcare worker is in a place where the ventilation is much better. But where possible, if you can put the transparent screens for interview rooms to basically protect the healthcare workers and maybe minimize even the need for more sophisticated PPE. So we have to look at different aspects. What do we do for the patients? What are the minimum things that we have to do for the patients? What do we do for the healthcare workers? What do we do for the common spaces and waiting areas? So that in our minds, it's very, very clear. So to come back to your initial question of the messaging about if you behave abnormally, this disease, if you behave normally, this disease will treat you abnormally. I think we probably need to change the narrative. And basically, I think what the CS is trying to say, and I understand its frustration, is that a lot of the things we say, people do it day 1, day 2. They did it maybe the whole of March. But come in May and in June, people don't wear masks. People are crowding. You'll find a place where a big group of people are seated. So I think what the CS is actually trying to say is you have to protect yourself day and night from this COVID. There's so much that the government will do, but most of the things will have to be at the individual level. So how can we, for all of you who are listening to this webinar, what can we do in a small little way to encourage people to adhere so that it becomes a personal responsibility rather than the police implementing wearing of masks and other things that are sustainable, to educate the public that whatever they do, it's for their own personal protection. They should not wear the mask for the police. They should not wear the mask for the CS. They should not wear the mask for the DG. They should wear the mask for their own protection. Let me stop there.
Okay, thank you very much, Dr. Mari, for that response. Anthony Wanyoro, please mute your device. Would you like to say something, Dr. Anthony Wanyoro? Okay, sorry for that.
Dr. Kalondu.
Yes.
You know, I personally like the CS's message. It's very clear. Yes. It's very clear that if you behave normally, this disease will develop, will treat you abnormally. That is a truth. I think our challenge is that the public does not fully understand this disease. So it is challenging us to build on that message to the next. And I think a discussion about what is the new normal would be the appropriate messaging. What is the new normal? Because for sure, you know, for sure, you don't use a mask and you go hang out in a public space, in a crowd, for sure, there'll be somebody who will live there with a new COVID infection. They may not be ill, get ill, but they'll take it home to somebody else. And the disease will spread. So the message, I think as Kenyans, we are fond of, we don't like to hear bad news. We always want to hear good news. We're in Hakietu mood all the time. But we need, I think, looking back at history of the flu pandemic of 1917, 1918, I've been reading one of the history books of Kenya. Nyeri district the medical officer of health there says there were 17,000 deaths. This is long ago. I think the medical officer of health from Taita had reported another number of deaths. This is real. So we need to work on our health messaging so that the public works with us. And I think maybe as a ministry, the gap has been that, I don't know whether you have a clear communication plan, using media experts, using communication experts to really package the messages going forward. But we can't.
Thank you, Professor.
Dr. Kalondo, may I just?
No, just hold on. Thank you, Professor Nduati, for your comment. And it's true, we really need to repackage our messaging, and we need to get the public involved and interested to work with us. So before I let Dr. Maureen talk, I'd like to give Professor Nzala an opportunity to give a comment.
Yes, thank you so much. This is interesting, and things are evolving very, very fast. I have been looking at literature, and now it's clear that in 1889, that's when the Russian flu, what they call Russian flu, which they thought was influenza, was actually one of the very first coronavirus that spilled into humans. And that virus is now endemic. It's actually OC43. So as we talk about moving forward, let us also begin to say that should this virus become endemic, what do we do? Number two, MEHS in the Middle East is endemic. Can we look at how Arabs deal with MEHS? Because it is there, it actually has an effect and it kills people. How do they deal with MEHS in terms of infection, prevention, control in hospital settings? And then the last thing I want to comment on, yesterday we had a very good discussion with insurance companies, including NHIF, and they clearly told us that insurance claims, health insurance claims, have actually gone down by 90%. And the question has been, where are the patients? So as we plan to return patients to hospitals, one of the things that I would like us to look at clearly, what is a waste? Because we keep saying health financing, but opportunities like this should now help us to calculate and find out when things were normal, what percentage of this normal was actually waste. So that as we go ahead, as we move to the new normal, we must prevent waste so that that new normal helps us retain more money and only deal with patients who really need to be admitted, prescriptions that we actually need to give, claims that are actually true. So let's not be one-sided just looking that we want to get patients back. Let's use opportunity to also calculate waste. If it has affected NHIF, and it has also affected the private sector, which did not say that patients should not go in. Claims have gone down by 90%. What is it telling us? So that is another discussion I want us to have, because we are the biggest stakeholders in this as we go ahead. Thank you.
Thank you so much, Professor Nzala. Thank you for that comment. It's true, prudent use of resources is something we need to think about, and avoiding waste as we go forward. Dr. Onyancha, we've not yet forgotten you, but allow me to give Dr. Maureen Owiti a minute to pass on our point. And then after that, after Dr. Maureen Owiti talks, Dr. Rosa Chemwe will take over the Q&A section.
Thank you, Dr. Kalondo, for giving me another opportunity. It's so wonderful to be the eminent professors in this group. I agree with what all my previous presenters have said. I just wanted to point out to Professor Nduati, some of the confusion arises from us ourselves, because even as we speak today, what clarity do we have on this COVID? Every day you get a new message from WHO Today they say it's not spread from asymptomatic people, tomorrow it's spread. So even among ourselves, we're not very clear what this COVID is. And therefore you find sometimes our messaging will be confused because we still don't have a clear-cut answer the way we are with HIV. I also wanted to flip on what Professor Anzala has said. Today, we were to have a list for EUAs. So it's again going back to our elective surgery. We do EUAs for patients with gynecological, mostly cancer of the cervix, and a few people with cancer of the endometrium. And we actually had 5 patients prepared, and of the 5, about 3 of them missed surgery because they didn't have financing. So I would agree, maybe in the private sector, we all know on Friday afternoon, for those of you who have worked in an OPD, you'll always find people who all of a sudden have stomach pains, and for a stomach pain, they always want a sick sheet. So yes, there is waste, but there are also those people who really can't afford these services. And next year, for the insurance company, I forecast, I don't have a crystal ball, but I forecast that the number of people who will be able to uptake insurance covers is going to reduce, because as we can see, a lot of people have either lost their jobs or have been, their salary has been reduced. So you find even packages that companies that used to take are going to reduce because of the economic impact COVID is having on the society, but that is yet to be seen. So in as much as, yes, there is waste, there are people who are suffering who will not be able to afford healthcare services. How do we help them access these services? Thank you very much.
Thank you very much, Dr. Owiti, for that elaborate comment that you've made. So, Dr. Onyancha, we have quite a number of questions towards the government who you're representing currently. What is the government doing about having a detailed guideline on reopening of these services? And more specifically, is there any place for telemedicine? And also, has the government considered moving some of the essential services to community level, for example, vaccination and family planning? And the last one maybe you can address is on stigma reduction when it comes to COVID-19 and the public seeking services. What is your response on that?
Okay, thank you so much, and thank you for those questions. But before I answer this question, allow me to just also make a comment and appreciate all those who have given their input. Professor is very right by saying that it is not. Sorry about that. Let me. Oi, I'm so sorry. It was a bit far, and I had to switch it off. Sorry. Now, I just want to say that I think as a professor and researcher, I just want, I don't want it to be operational research, to be able to come out very clearly and separate between the West, because of the reduction, what proportion of what we are seeing is as a result of West, and what proportion is a result of fear and stigma as far as COVID is concerned. Because I know people have been saying that what they've done, some have actually resorted to using other means. Some people are going to witch doctors, people are trying remedies and whatever, just to avoid going to work. So whereas we know for sure some of the hospital visits and attendance and admissions are maybe unnecessary, but we would want really evidence that what proportion of, especially the ones who have reduced, are really purely because of the fear, stigma related to COVID, and which one are they as a result of the West. The second one I want to comment is I want to agree with Professor Duarte that for me, the message of if we behave normally, we are not behaving normally nowadays. We are on masks, which was not our norm. We are actually always washing our hands. We are keeping distance and whatever. That is what, to me, I get from that message, that indeed we are not just going to continue the way it was. We were, otherwise then we will be able to suffer, and even the infection will be very high, depending on how you perceive, how you take the message. And I think finally, there's somebody was saying that we may want to change the messaging It is true, I've just come from another Zoom meeting where we are discussing the issues of stigma and its impact on these services. And it is clear that as we go, as the disease evolves, some of the messaging will have to be redone. Even the guidelines are being redone. There's nothing that is cast on stone. And therefore, we are actually learning as the disease evolves, we'll also be evolving in guidelines, in policies, and even in the messaging. So coming to the question which you've just asked, the reopening that we want to have. In the first place, apart from maybe we were told that there were those very unessential or not emergency services which were put on hold so that we see how the disease goes, I think the services were supposed to continue because the diseases which existed did not fear COVID. They were coexisting and therefore they had to continue. I had a directorate whereby it is the one which is addressing TB, addressing HIV, malaria, immunization, and family health, meaning that we really had to make sure that we have given guidelines that you see what, we must continue with that services even if we have COVID, we are responding to COVID. In fact, WHO has even written a report and even has written to the CS showing that in West Africa during Ebola response, they lost more people, for example, to malaria than to Ebola itself. And therefore, we must make sure that the other diseases are actually given attention as much as we could have done even without COVID. I like what Dr. Maureen is saying. It is a different new norm, but services must continue. It means that maybe we have to expand, we need to have, it is using more resources, but services must be given as they were. The role of telemedicine, if you check in the, I think is it in our website, especially the guidelines on maternal and child health guidelines. We have even gone ahead and operationalizing them. We are at the level of buying now handsets to all public facilities, which are over 5,000, that they will be using this platform to be able to actually communicate with the mothers for ANC, for child immunization and all that. The plans are at a very advanced stage. And because Safaricom has agreed to even give us to reduce the rates, Communication Authority has already given us the need to actually go to this platform of using telemedicine, especially tailor-made at this moment to the maternal and child health services, but it will be used by the facility for all the other services. So it is something that we are very keen on as a government doing going forward. In terms of community level services, we know even before COVID, that was going to be the vehicle and the intervention as far as healthcare, universal healthcare is concerned. So as we speak, yesterday, we completed sensitizing about 61,000 community health volunteers on the approach interventions on a new module to be able to integrate all the services to be given or delivered by the community health volunteers. We are training the community health assistants and courtesy the Universal Health Coverage Fund in the KMTC to be able to assist us. And in the next 2 months, we have actually already set structures to be able to have community health units covering the whole country, because we have a deficit of that 1,000, which is going to be established by Red Cross through the money that we have given them. So community is very key. And in fact, things like hand washing, just the IPC will be communicated better through the community health volunteers, because these are people who go from one household to the other. So we are really harnessing the community health services and improving it, so that, because that is an area that we have seen that would have a very high impact approach to that. In terms of stigma, as I've said, we have realized is one of the key driver of low service utilization, and we are addressing it in terms of changing the communication out there. And then we have talked of actually concentrating more of the positive than the negative, so that people can now come out to the reality and say, as much as COVID, the way it came from the fear and the panic, we are at a point where we are going to norm and be able to coexist with it and see it as any other disease. And I think all of us know that even when HIV came, when new diseases come, that is the trend it is. So we are going to reach a point where we emphasize on the positive aspect of even the disease, COVID, and I know there are many. So as the guidelines we are coming up with, I think the latest one will be how do we address reduce the stigma. We just found out that people, the communities even themselves are coming up, like what happened in Muranga, whereby they actually appreciate the people are coming from the quarantine, from isolation, and they are embracing them. Such things, I think, is what we need to now emphasize on the positive and the positive aspect, so that we can be able to fight stigma, to be able to allow health services to resume normally in the new norm. Thank you.
Thank you very much, Daktari, for that elaborate answer. It actually gives us quite a bit of confidence that the government is doing something to get things back to normal. So I'd like to ask Dr. Odhiambo on two things from the participants. One is, how is the traffic control going to work when the services resume, the dental services? And then two, apart from using gun thermometer, what other measures are going to be implemented as part of the screening? Dr. Walter Odhiambo.
Thank you. Thank you very much. The issue of remote consultation and risk management from remote areas we had discussed before, that it would be, I don't know if it is still relevant. There are measures we had discussed which were necessary in the initial stages when we were talking of only the clinics were closed and they were only open for emergencies and caring for people who are probably likely to need attention and would get worse. But when we are talking of returning situations to normal, I think what we should look at is generally the situation of the country as a whole, not necessarily urban centers. And some measures may apply in Nairobi very easily. Those measures will not be able to be applied in some very remote rural areas. And also, probably it is a challenge to the ministry to look at whether we need a uniform national response or these responses should be kind of tailored to suit specific environments. The thermometer sensor, which has been used in restaurants and so on and everywhere, I am not sure how much science and feedback they have got and how many people have been picked or kept out of restaurants because of abnormal temperatures. And you will find places like in Nyanza, where malaria is endemic, you might have a lot of problems with simply using the thermometer to sense who is at risk or who is not at risk. So I would really like our local scientists to look at our situation as Kenyan situation and not necessarily tailor-made WHO experiences, which have guided us so far in the last 3 months. That we have had our 3 months for now. And my thinking is that if we open up like the dental schools or the clinics, yes, the thermometer remains our initial test, but the first and foremost screening should have remained phone calls and clocking the patients, taking their history of contact with anybody who has been exposed to COVID, or if, for example, patients are coming from an area which the ministry has outlined as an area where there is suspected cluster, for example, like the last time Isili was locked down, now we are saying Kibera as clusters. Maybe one would look at patients coming from those areas and try to ask questions that might lead you into establishing their contacts and conditions. But generally, it is very difficult. If we open up for the entire community, then I think the precautions we should take should apply to all patients. In this case, for the dental clinic, the procedures are generally aerosol generating, and the dentist therefore must take all the necessary precautions, wear the gowns, eye goggles and shield and the mask, and the patients, probably there's no way you can treat a dental patient with their mouth covered with a mask. So we will have to take all those necessary precautions that you can practically take. But if, as the ministry says, we should open up, then most of the measures that we take should be the routine measures of infection control. And the waiting room areas, previously we had described them that they should have space for distancing where patients are sitting. They should have appointments that are spaced so that patients do not combine in appointments. And patients should not be accompanied by unnecessary people, escorts to the clinics, so that you only have absolutely necessary number of people attended to. But we are agreeing that it is necessary to open up the clinics, and it is necessary for now to resume routine dental practices with the necessary precautions. That's all I can say. I'm not sure. All this, we do not have science that has informed us as of now. We do not have clear science that the use of digital thermometers would probably help to identify patients at risk better than any other means. We do not, there are people who have even talked of the use of pulse oximeters to try and see the level of partial pressure of oxygen, but that is still all in theory, and nobody really has evidence to support all these measures. I looked at the paper which was published by some colleagues, including Professor C.F. Otieno, the Dean School of Medicine, among others. It's Jenga et al., and which were looking at the low cases of COVID-19 morbidity and mortality in Africa. And they had a lot of hypothetical suggestions. One key fact which emerges from that is that we local scientists need to rethink and define what parameters we will use to contain the spread, but at the same time reduce the fear and stigma. And so long as we have these lockdowns and so on and so forth, you expect the numbers in the clinics to be low, because there's restriction in travel, there's restriction in interaction, people are not going to work. So we expect that the numbers in the clinics will be low. And that's really the problem.
Thank you very much, Dr. Odhiambo. It's actually very interesting, because in all disciplines, infection prevention and control will still carry the day, no matter how kind of screening that we introduce. So thank you very much for that response. Kennedy, you have your hand up. Can you ask your question? Kennedy? Dr. Wambani, you can take up. Kennedy is not responding.
Thank you very much for this session. I've learned a lot and a lot of encouragement from our professors and the doctors in different disciplines. Now, it is coming out very clearly that we need to relook at the health budgets and reorganize our health services. And more so, we look at zoning. I think most of our institutions have a lot of space, and the zoning will not be a difficult thing to do. I think in terms of social welfare, I think COVID has brought us to the same sort of economic status where the rich and the poor are on the same social status, because you cannot even use your money if you have it. COVID has prevented you from doing what you are to do. So again, I think that is an area that we can now as health professionals concentrate on and use it to change our message. The message that was sent at first was very good because it alerted everybody. Now we should say, use that status, that we are now all on the same status, and we change our messages and say, we are all now on the same status. Please reorganize your health, hygiene, and so on. Make sure that you make use of the status to develop other messages that would touch on the population. And natural homeopathies, I think that is another area that we can also zero in. In our hospitals, we should now have sections where people want natural, cultural, herbal treatment, and other areas, modern medicine. I think we can also look at that as a possibility, instead of just saying that people have resorted to herbal treatment. We can actually develop that, and I think Kemri was in the process of looking at the natural herbs that are medicinal in our setup. Thank you. Those are my comments. I don't know whether they will make any sense into.
Thank you very much, Dr. Wambani. Truly, COVID has made us think outside the box. So the strain it's putting on our healthcare system, we probably need to think outside the box. How can we reinforce it and make it much stronger for future pandemics or epidemics that would come? So this is an opportunity for us to actually work on that. So I would give a chance to Kennedy to ask a question. Your hand is up. Beatrice Wangoi, you have a question? Dr. Alanikon, you guys have your hands up. Do you have a question to ask?
Thank you very much for this opportunity, and thank you to the presenters. As all presenters have alluded, that with COVID, we need to maintain more social distancing, whether in public or in the private hospitals. But among the few things we need to look at before even we start thinking about telemedicine and all that is, one, we have a structure and organization of, especially if we look before, of government hospitals, whereby there's been a level 1 up to level 6. Ask yourself this: is it that before even COVID, is it that we were having overcrowding in level 6 and level 5 only, or we are having crowding in all the levels of healthcare? Because you find, based on the old model of care, you should visit level 1 or level 2 or level 3 hospital before you get a letter of referral to a level 5 or level 6. But you look at now, how do patients seek healthcare, whereby a patient wakes up in the morning and goes to a level 6, or everyone believes that level 6 is the level that you'll be attended to the best. So we need to go out also with a different narrative, whereby we should educate patients that you cannot only get service from a level 5 or a level 6. You can also get the other services from the other levels, and if need be, that's when we will refer you to level 6. You'll find this will lead to different hospitals handling different levels of disease that they can handle, and then we leave a level 5 and level 6 to the cases that is deserving to those levels. And then the other thing is that overcrowding is also sometimes, it just shows that it may be a gap, either in terms of the number of hospitals we have, or two, we as healthcare workers, are we really working? That's the question we need to ask ourselves. The other levels, are they in their centers of work, or they are not there? It's only that maybe level 5, level 6 is whereby people are offering healthcare.
Thank you very much, Ecole. We actually need to have our referral policy, the national referral policy, to be implemented. And the suggestion you make will actually come to a realization. So we have a comment from one of our participants who works in the HIV clinics, where Dr. Onyancha had commented before that there is concern on HIV attendance reducing. And what some of the clinics have been doing is they're using the Ushauri platform to send messages to their HIV clients and reassure them that there is service continuity and provision of ART refills for 3 months. So maybe moving forward, there'll be refills for 6 months and a policy developed on how to go about this challenge in view of the new normal. So we have reached at the end of this session. We would just give Dr. Onyancha your last parting shot, the message you'd want to give our participants before we call off the session.
Okay, thank you so much, Dr. Kalun, for that. And I want to appreciate KNH for this kind of forum. I can see you even have a timetable, and I think I will ask to be sent so that when I have time, I can be able to be joining, and indeed it's very exciting, learning a lot. What I want to say is that I think as a government alone, we cannot manage, cannot have the capacity to respond. What we do is giving direction and policies that guide. And indeed, in such a forum, I'm excited to see that indeed you are able to attract so many people. When I saw the participants who have actually 1,025, indeed the message is passing. And this is one of the things that we should actually say, that COVID has made us to be computer and to be able to use the ICT platform more, and you are able to reach out to many people. Coming to what we've been discussing, it is a high time, and it is a good thing that you have actually realized that indeed we cannot continue like this, and that we are going to start and to adopt a new norm. And that new norm is to make sure that nobody suffers unnecessarily because of the diseases or elements that could be addressed by us, because we have been maybe concentrated on COVID. So going forward, I think the Secretariat, I want to believe that they'll be able to put up what we have discussed, and this will really go a long way to be advising in the strategies and the guidelines on how we are going to go back to our norm, which is going to be a new norm, that then make sure that we are able to continually maintain the essential healthcare services. And I think the word essential really also touches on what Professor Ansala said, that we don't want necessarily to promote wastage, but at the same time, we don't want to affect services which need to be given to the people by really concentrating on one. So I want to appreciate the inputs, the issue of maybe looking at health. This one was commented that we may want to have a new business model for delivery of health services in the health sector, and is welcomed to be able to give his ideas as how we can be able to turn around, how we are able to change so that we are able to be more effective in this low resource environment. The question of looking at the health budgets and all this zoning and all that, those are ideas that are most welcome. And indeed, we must find a new way of doing things. I think having been constrained, I think going forward more, it's more constrained. You can imagine when we used to have services and nobody could think about PPEs, nobody would think about space, meaning that you needed more space and more space even in clinics. That asks for resources, and we really must know how to utilize resources which are already not there. My parting shot is that in this approach, the most important thing is actually behavior change to be able to adopt the new norm, and the behavior change to be able to respond as we are directed from the policy making, the guidelines and the strategies. This cannot be done by one person. We are all together. We must pull together in whatever way. Just what the late Professor Wangai, that like a hummingbird, even when you are taking water with your just little beak to be able to put off a forest fire. Let us do what we can be able to do to be able to see that we have brought actually the normalcy in our health sector in the delivery of health services. I will wish you the best. Continue doing this woodwork. And indeed, I will be able to report that Kenneth, you are doing great. I can see, and thank you for all those who have actually joined and given their valuable contribution, both on the chat and even in the question and comment, because it has really informed us. Finally, I would request that if you can really give us maybe all the questions that have been asked, they would be able to inform us. We may not answer the person who asked, but it will be something that will be able to help us going forward, even as we come up with different guidelines and different policies. Thank you so much. And thank you for giving me opportunity to share what we are doing at the Ministry of Health. Thank you so much, and bye.
Okay. Thank you very much, Dr. Onyancha, for taking time as well to share with us what you're doing at the ministry. Much appreciation to the participants who have stayed with us on till now. Thank you for making time, and all our expert panelists for your comments and your questions that you have contributed. So remember, on Monday, our session is in the evening on adult inpatient COVID treatment protocols. And we are getting a presentation from the local management of COVID inpatient, and also from the US. So thank you very much once again, and enjoy your evening.
Thank you for a wonderful coordination and putting us together. Thank you, Dr. Klundu, and thank you for everybody. Bye.
Thank you. Have a nice weekend, everybody.
Thank you,
Bye-bye.
Dr. Kalando. That's
Thank you for the
I'm really
invitation.
grateful.
Thank you for everything.